Really great to be with you all today and to give you a bit of an update of some of the things going on at Stanford. One disclosure slide related to some assessment tools I helped invent when at Mayo Clinic, which Mayo owns and is licensed and shares some royalties related to those. So in a vein of CME, share that. What I'd like to do with our time this morning is to give you a really brief update on where are we in the aftermath of the pandemic with respect to clinician well-being and physician well-being specifically, to think a little bit about some of the causes, and we'll focus actually here on some of the newer and emerging driver dimensions, and then spend most of our time thinking about system solutions and very specifically to discuss what's happening at Stanford. With that, let's dive in. And it goes without saying that it's hard for us to approach the topic today without having our view colored by the pandemic. I think it's notable to reflect that, 4 years ago, we were really at the very beginning of this, and to consider how much has happened within 4 years and the many twists and turns that has brought. But as all of you know, this challenge of occupational distress, work-related distress, professional distress in physicians and other healthcare workers has existed for several decades. And in that sense, the pandemic was just an acute on chronic stressor. It certainly wasn't the origin of this. And even though we're sort of through the worst of the pandemic, it appears that the aftermath is something we're still dealing with. And I'll show you some data on these trends in a minute. Before we go too deep, however, I do always like to emphasize that as physicians, we're not immune to the individual personal mental health conditions that can affect all human beings, such as those listed on the left side of the slide. The data suggests we're at about the same risk for these challenges as other working US adults. But it's the dimensions listed on the right side, different forms of occupational distress, that the data suggests we are at markedly higher risk for challenges in these domains as physicians than workers in other fields. Burnout is the most prevalent and best studied of those challenges, but not the only one, and it really a multifaceted challenge. Before I project some data, again, I just always like to anchor. We all use this term in a colloquial sense now in today's world, but when we look at it from a research point of view, we're referring to this very specific occupational syndrome. This is not pop psychology. This is a WHO-recognized syndrome with these three elements of depersonalization, emotional exhaustion, which is losing your enthusiasm for work, and then that low sense of efficacy, and you're no longer making a difference. We all have those feelings in our work to some frequency and severity, but when they come too often to too severe an extent, they undermine effectiveness in work. The syndrome primarily affects people whose work involves intense interaction with other people, teachers, social workers, police officers, clergy, and healthcare workers. So this is where we were almost a decade before the pandemic, already a big problem. So this was prior to 2011, we had large single specialty studies, large single medical center studies, but this was the first cross-sectional look, all physicians, all specialties, all practice settings in the US, and using the gold standard assessment. About 45% of physicians had a high score on the burnout assessment tool. You note wide variability by specialty, no discipline immune, but many of our colleagues at the front door to the healthcare system, emergency medicine, general and internal medicine, neurology, family medicine, among the highest risk groups. Now, we have looked at the point prevalence of burnout in US physicians and US workers in all other fields, basically every 3 years since the time of that study. And I'm going to show you the most updated information in a minute. But this was sort of the trend prior to the pandemic, with the physicians in red, a probability-based sample of US workers in all other fields in blue. You note this gap, higher burnout in the physicians, when we adjust for age, gender, hours worked, relationship status, and level of education, this gap actually gets larger, not smaller. And you note that this sort of unfavorable trend exists for both burnout and satisfaction with work-life integration. Some fluctuations over time. Those of you who were practicing in this window, remember this was when the High-Tech Act went into effect. Meaningful use of EHRs was basically required. EHRs pushed out maybe before they were fully ready. E-prescribing, a number of new regulatory elements, a host of changes in the ecosystem that possibly contributed to this 10% increase, and then some improvement. The one other point I do like to make here is when we use the population as the anchor point and look at the experience of other healthcare professionals. We did a similar study with the American Nursing Association in 2017, national study of PAs and NPs at the same time point. And the curves looked a little different at that point in time, pre-pandemic by discipline. So for PAs, their daily work has a lot of similarities to physicians, and relative to the population, they were at markedly higher risk for burnout, but they tend to work fewer hours than physicians, and their satisfaction with work-life integration was superimposed on that of the general workforce. Pre-pandemic, nurses actually had the reverse profile. They were doing actually similar to the population after adjusting for age, gender, work hours, and other factors, but the satisfaction with work-life integration for nurses was markedly worse, and that was their challenging dimension. Last thing before we transition to some new data, I have shown you this before, but I think it's important, and we're going to anchor to this when we talk about some of the efforts at Stanford. Is this like looking at satisfaction with work-life integration on the y-axis, burnout on the x, the intersecting lines, the average for all specialties, and the dots you see different disciplines. And a couple of points here. One is that we tend to project that these domains will travel together, both favorable like in green or both unfavorable like in red. And you note that's sometimes the case, but not always. Here's emergency medicine, always the highest rate of burnout when a standardized scale is used. But they actually work the fewest hours of any discipline in the US, an average of 44 hours a week, and they have above average satisfaction with work-life integration. Their foil, and this is from the 2014 study, was neurosurgeons who had slightly below average rates of burnout, but by a large margin, the lowest satisfaction with work-life integration. At national levels, they work the highest number of hours of all specialties, an average of 65 hours. So you begin to appreciate that maybe what the emergency medicine physicians need and desire might be different than the neurosurgeons. If I plot something different on the y-axis, if we change that to fatigue, all the dots shuffle. If we change it to meaning in work, all the dots shuffle. One of our most recent looks is isolation in a paper that will be soon submitted, all the dots shuffle. And so what you begin to appreciate is that each specialty has a profile, and an interesting example, you see pathology right there in the middle, kind of average when we look at these dimensions, but when we plot isolation, they go down to being the least favorable. That is one of their great challenges for pathologists. So we have to understand that diversity and begin to think about how do we approach it if we want to get at the things that really are contributing for people. The last point here is this is not only about money. Here's orthopedic surgery, one of our highest paid disciplines, next to family medicine, one of our lowest. And many of our lowest paid colleagues, psychiatry, general pediatrics, were there in the green. Now, this was the most recent published update, which was the survey in December of 2021 and January of 2022, just about 2 years ago. You'll note that at that point in time, we did an off-cycle assessment. We didn't have the population, so this was sort of at the 18-month mark rather than our typical every 3-year. You see this very large spike with burnout at the highest level it had been relative to the preceding decade, satisfaction with work-life integration at the lowest. And the data for other healthcare workers looks very similar. This is hot off the press data. You're the first to see it. So the most recent survey was conducted November of last year through February of this year. We literally got this data about 2 weeks ago. So where are we now? And I'm showing you data for general internal medicine. I'll show you internal medicine subspecialists in a minute. And what you note is that there has been substantial improvement over the last 2 years in emotional exhaustion, depersonalization, these are the mean scores, and the percentage of people scoring in the high range. And yet, although there's been improvement, we're still at the highest level in several of these areas relative to any time point other than 2021. In contrast, for general internal medicine, work-life integration has not only recovered relative to 2021, it's actually similar to where it was in 2011. So a lot of room to improve, obviously, but this dimension is looking more favorable than it did for most of the last decade. And here you see the percentage change relative to just to 2021. And the last point I make here is you look at these large swings in these domains of occupational distress at the top of the table, very subtle changes in depression scores, just making the point that this is not general distress. This is work-related distress that we're seeing as the challenge. Now, when we look at internal medicine subspecialists, the data look a little bit different. Like general internal medicine, there has been this improvement in these dimensions of burnout. But not only are they better than 2021, you'll note that some of these are the best scores that we've seen in internal medicine subspecialists, recognizing that's a heterogeneous group and we're pooling endocrinologists and cardiologists here, that we're seeing actually pretty favorable burnout scores and lower than general internal medicine, but almost in a mirror image, work-life integration among internal medicine subspecialists lower than general internal medicine. And this dimension, although the burnout scores are better than the last decade, this dimension is still unfavorable relative to many of the other time points. So again, just illustrating some of these different dimensions of work-related distress affecting different specialties differently. So let's just briefly consider consequences in one slide. Obviously, all of us are familiar with the data on some of the personal individual consequences, but over the last 2 decades, it's really now the overwhelming evidence on outcomes for our patients, our communities, our care delivery system with respect to errors, decreased quality, lower patient satisfaction, turnover, and decreased productivity that have really heightened system-level attention and action. And there's an infectious quality to burnout. If the members of your clinic group or your division begin to experience this, they just start referring to the work in ways that are more cynical, more jaded, and it rubs off on the other members of the unit. Traditional sources of distress I'll summarize in one slide and then show you some new data on some emerging drivers. You all are familiar with these things. We just have a greater focus on productivity, increase in clinical demands over the last several decades, many of these new challenges entering our practice. That last bullet is just important to note that our colleagues have always been one of the things that sustain us. That's always been true in the profession of these incredible people that we get to work with, who are dedicated, altruistic, hardworking people who make a lot of personal sacrifice to care for others. And as all of these other changes have just squeezed time out of our day-to-day, we just interact with our colleagues less, and that's a contributing factor. A resilience deficit is not our problem. This is data from the 2017 National Survey using a standardized resilience scale. Physicians, US workers in other fields, no surprise, physicians higher resilience than workers in other fields. We wouldn't have survived training were that not true. Within the physician population, as we move from lower resilience scores to higher resilience scores, burnout goes down. So we do want to encourage this, even though it's not the primary root problem. But emphasizing even out there at the right, people with the highest possible resilience score on this scale The current system is burning out 30% of the most resilient people on the planet. So we won't resilience our way out of this. We obviously have to talk a little bit about how the EHR is impacting us, even pre-pandemic. About half our workday was spent interfacing with the EHR. We were taking a lot of work home on nights and weekends to be performed on personal time to complete our work. Volume of inbox messages and computerized order entry were found to be the dimensions of EHR use that were most strongly related to distress. And some of this is Epic's product or Cerner's product, but other parts of it are really something that manifests in the EHR, but is not due to the EHR itself. So the simple example here that a patient seeing their endocrinologist for a diabetic follow-up visit at Stanford today has a note that's 4 times longer than a diabetic patient seeing their endocrinologist in Paris, France today. And that isn't necessarily because the care is different. It's because what is it required to bill? What is it requirements to practice defensive medicine and so forth? And patients around the world use their in-basket function very differently. So this is a big issue and one that the pandemic has profoundly altered. This is data from AJ Holmgren and team at UCSF. He took the universe of Epic data from all healthcare systems in the United States using Epic, pooled it, and this is what happened to EHR inbox messages the first month of the pandemic as we transitioned people to virtual care. A domain we already knew had a dose-response relationship to burnout, worsened by 50% in a single month. I think one of the other things that happened about 2 years ago, which would have been an absolute earthquake had we not been in the middle of the pandemic, was the HITECH Act, which required immediate release of all labs and test results to patients as soon as they were available. And the data from Vanderbilt shows that 40% of the time in today's world, patients see the test results before any member of the care team. And they were able to show prior to implementing immediate release compared to after immediate release that when patients see the labs in that manner, the number of messages they send doubled with that sort of immediate release of data. So this has been a challenge pre-pandemic, but profoundly exacerbated by the pandemic. And there is a substantive gender dimension to this challenge. This is data from a number of investigators. Lisa Rottenstein and her team have been some of the leading experts to study this. Women physicians receive more inbox messages from both staff, other members of the care team, as well as patients after adjusting for visit volume and panel size and all other characteristics. And I think this just begins to illustrate one of those subtle and insidious ways that there are gender differences in the practice environment that are not always intuitive. I think, a lot gets attributed to societal expectations for professional women, some of the mistreatment experiences and other inequities for professional women. But here's a very subtle way in which the workload is different that we were all blind to until these investigators begin to evaluate this. If you look at time spent in the EHR per 8 hours of scheduled clinic time, women spend about 30 to 40 minutes more per day. The increased volume I just showed you during the pandemic was true for both men and women, but the magnitude of rise was greater for women than men. And there's some evidence that this extra time spent in the EHR actually is promoting better quality of care. The outcomes measured in this study were things like hypertensive control, A1C control, breast cancer screening, and the like. And so this is valuable work. It's just, again, we don't have care teams designed to do it. So it's coming out of people's personal time. And women spend more time on clinical documentation, but are less likely to receive documentation support. So again, I think just an example of subtle ways that there are gender differences in the practice. The EHR also affects us not just on personal time on the average clinic day, it's profoundly intruding into our time away from work. This is a study from our national investigative team that Krasinski reported about 6 weeks ago. 60% of physicians take less than 3 weeks of vacation a year. I think perhaps most disturbingly, 1 in 5 physicians has less than a week of vacation each year. Most of us perform clinical tasks on vacation. I would emphasize this is not cleaning your email and writing a grant or writing a manuscript or preparing a talk. This is clinical work being performed on vacation. Only half of physicians nationally have inbox coverage on vacation. Probably the number is about the same at Stanford. Half of our colleagues have good coverage, half do not. And a third of folks are spending more than 30 minutes per day working while on vacation. And what you'll note here is in the multivariate analysis, these vacation characteristics of did you have at least 3 weeks or not? Did you have inbox coverage? And then how much time were you working on the average vacation day were all independently related to risk of burnout in the multivariate analysis. All of those examples about inbox at night or on vacation are just a partial look at how work adversely impacts personal relationships. This is a domain our colleague in the WellMD Center, Mickey Trockle, has really been studying for a decade. And this is a most recent look from one of our national studies that Mickey has in press. And what you'll note is that 40% of physicians say that work is having an adverse impact on their personal relationships, with 20% moderate and 20% high adverse impact. In the multivariate analysis, women, single physicians, and those with children age 5 to 12 are feeling the greatest challenge in this domain. And what's notable is when we adjust for that dimension, if we control for how much work is adversely impacting personal relationships in physicians and workers in other fields, that actually abrogates the increased risk of burnout in physicians. After we adjust for hours, gender, relationship status, scores in this dimension, that difference is gone. So, working on this aspect is a really important challenge. And so I'm going to talk about what are we doing as we go forward. So just the last few slides before we think about solutions, many other changes that we're all dealing with in our practice environment where we feel measured to death. We're excited to see medical knowledge grow, but reading all of that literature on our personal time is one more challenge. So we give this person a hard hat and ear protection because things fall on his head. And I hope what you take away from those last several slides is that the work injury that's happening to us as physicians is related to these dimensions we just talked about. And what's the equivalent of the system protective approaches we're instituting for physicians so that they're not injured by their work? How do we address this issue? And here, we view this as an 80-20 problem. There are things we can do as individuals. We are not powerless victims. We should do these things, but that's the minority of the problem. And so we need to give a greater focus to the system issues. And when we think about the system issues, one of the key elements are some of these workload structural challenges in the work environment, like we were just talking about. But there's a second side to that coin. And I'm going to come back to this at the very end of the talk about characteristics of our professional culture that are also contributing. I think all of you are familiar with our Stanford model of professional fulfillment, developed by Brian Bowman, which has really become the dominant model across the US and increasingly worldwide, where our goal is something more aspirational than eradicating distress, promoting high professional fulfillment. We have a three-legged stool. There are those things we need to do for ourselves. But really, we need to attend to this organizational culture of aligning the organizational values and the values of healthcare professionals, giving people agency, behavior of leaders and support, and then addressing these inefficiencies in the practice environment. We often think about operationalizing that by addressing these 7 areas: workload and job demands, efficiency and resources, giving people flexibility and control, optimizing meaning, aligning culture and values, fostering community, and fostering work-life integration. When these are suboptimal, they're pushing us to the left, more optimal, pushing us to the right. And our challenge as an organization is that each of those hexagons is influenced by individual factors, unit factors, system factors, and national. If we think about efficiency, not all the hematologists in our clinic here at Stanford are equally efficient in the way we practice. All of our efficiency is impacted by how we triage and schedule and arrange for chemotherapy. How we arrange chemotherapy matters to BMT and medical oncology and hematology, but not to most other areas at Stanford. But they have their own challenges. And then there are system level factors that affect everyone's efficiency, and insurance pre-auth is bigger than Stanford, but impacts us. So how do we operationalize this? And what I'd like to do with the rest of the time is give you a little bit of an insight of how we're approaching this at Stanford. And to make progress, we have to both do the broad things that benefit everyone, as well as address those unique needs in each of these departments. It goes without saying that having a slogan doesn't help us. Saying we aspire to be an environment where all of our physicians and clinical colleagues and healthcare workers thrive doesn't actually get us where we need to go. We have to put into place the structure and process to achieve that goal. Philosophically, we need to embrace this notion that all of us own this dimension. Just like we would say all of us own quality, all of us own this dimension of fostering professional fulfillment. We need this system approach. We have to put into place the infrastructure, implement tactics, execute, and measure. So with the rest of the time, I'll spotlight how is that happening at Stanford. And you'll see here in the upper left corner some of the system level things. So that's where we'll start. From a metric point of view, what's being assessed, this is what's on the Dean's scorecard of preeminence metrics of both an external measure of our structure and process at Stanford to foster physician professional fulfillment at the most mature level. And then also looking at what percentage of our departments are scoring favorable by a meaningful effect size relative to their specialty-specific peers, both nationally and at our peer academic institutions is what we measure. And we have seen some progress. And then similarly, same dimension for professional fulfillment relative to national specialty-specific benchmark and peers. And then what percentage of departments have a meaningful improvement project addressing problems in the work environment. For the adult hospital, there is also real estate there for David Entwistle, the CEO and operational team scorecard around the wellness and engagement. Some of this is for all employees, but here again, our structure and process work. And you'll note creating a respectful work environment, which is mitigating mistreatment by patients, families, and visitors. And then valuing our time of physicians in the operative environment and in the ambulatory environment, where here it is specifically about reducing in-basket burden and time on documentation. Now, there's a lot going on in the organization. This is a partial list. I wish I had time to talk about those with the arrows. Tremendous work implementing some of the recommendations from the Mistreatment Task Force from 2019. Dr. Weinecker has been one of the leaders of this effort, along with Anthony Alabastro and Deo Beatty. From our WellMD Lactation Support Task Force, Dr. Susan Crow is now leading the WellMD Lactation Council and has made great progress here. Faculty development opportunities that Dr. Maldonado's team is advancing. The CE Task Force led by Drs. Subak and Mary Leonard. And then support for faculty across the life cycle is work that Linda Boxer and her team are doing. So there's huge initiatives going on in those domains. But I'd like to briefly spotlight EHR support, this impact of work on relationship domain, safety net resources, and then how are we approaching system level action. What does the EHR impact look like at Stanford? This was data from the 2022 survey, Likert scale 0 to 4, higher unfavorable. And you see which areas of Stanford are feeling the greatest pain related to inbox burden. Department of Medicine was fourth from the top, but that's misleading because here's what the data shows at the division level in the department, where wide variability in pain in the department. And if I look at these scores, there are 6 divisions in the department who would be the single greatest pain point at Stanford in this domain, where we're plotting them on the left scale. So a huge challenge, and this data was used by the hospital to begin to prioritize what areas are we going to work on first. There now is a management governance team being led by Dr. Justin Coe in dermatology, as well as Heather Flipowitz. They have these 6 dimensions that they are working on. I'm going to come back to the top one. We want patients using the portal correctly. We need to eliminate unnecessary messages. They are now leveraging AI and other variables to develop some automated responses, delegating to other members of the care team. But this first one here, the work Justin and Heather are doing is really remarkable in that this notion of valuing the work means that the hospital needs to either help provide perhaps a recognition from a compensation point of view, or funding to support different care team models so that there are more physicians, nurses, APPs able to do the inbox work so it doesn't spill over into personal time. So really exciting work that you're going to be hearing about rolling out soon from Justin and team. What about this impact of work on personal relationships? Let's talk about it at the system level first. The WellMD and PhD Center had a small grants program that we rolled out a year ago, offering $50,000 to departments that would put forward a proposal of a structural change, scheduling, staffing, cross coverage, different team models of care to mitigate the adverse impact of personal relationships. We gave priority to departments that offered matching funds to the investigator they were proposing. We had 14 departments submit awards. All of them offered matching funds. We were able to fund fully or partially 6 awards, and many of the others are moving forward, even though we didn't have funding support for them with support from the department. We now have earmarked dollars in funds flow from the hospital to incentivize departments to work on this domain. And we also, to complement some of these system level efforts, have launched these recharge retreats for physicians. This is an initiative that Dr. Gold leads for our team. And we've had 3 cohorts now open to all faculty, where we bring physicians and their significant other, or physicians who wish to attend individually, and now a separate process away for a free weekend to connect with each other, engage in some intentional planning about how to mitigate this adverse impact on relationships, so that we're working at both the individual level and the system level. Before we look at the department, I'll just ever so quickly highlight some offerings to individuals. And again, won't be able to cover all of these, but I'm going to touch on those with the asterisks. In the same way that one of the things that's always sustained us are our amazing colleagues, another thing that always has sustained us is the work we do. The work is actually intrinsically meaningful. Most of us approach our work with a sense of calling. And in this study, what we looked at was 450 internal medicine subspecialists. We asked them what was the most personally meaningful aspect of their work. We then looked at how they spent their time. And if you spent 5 to 10% time in that most meaningful area, burnout 50 to 60%. As you spent 10 to 20% time in that most meaningful activity, burnout in the mid-30s. As you went over 20%, burnout dipped below 30. And that last 30 explained by work hours, call schedule, specialty, and other factors. But did you or did you not have 20% in that most meaningful area was the strongest driver of burnout in the multivariate among the variables assessed in this study, which was almost 15 years ago now. And so how do we harness this? And this is one of the reasons I think professional coaching can be so helpful. This was a study we launched about 8 or 9 years ago. Lottie led this trial, and we enrolled roughly 90 physicians. It was a randomized crossover study, immediate versus delayed start, 6 executive coaching sessions. And you'll know, this is not health coaching. What's the domain number 1 that physicians wanted coaching on? And it was what we were just talking about. So this is a concept. This is how do we operationalize it? The second one, integrating personal and professional life. And then you see some of these other aspects. And in this trial, absolute rates of burnout went down 17% in the immediate intervention group. So from 40% burnout to 23%. Other benefits you see listed on the right. And there now have been 6 additional randomized trials published in both residents and fellows and attendings. One by our colleague Carrie Palmera McGrath from Mass General came out last week. And all of them, we have 6 randomized trials saying this is an effective way to both reduce burnout and improve professional fulfillment. This is available to you at Stanford. There's 2 offerings. Hopefully, all of you are familiar with the WellConnect program that Dr. Trockle leads in our Department of Psychiatry and a group of our psychiatrists and psychologists. And this is 24/7 free mental health support with no documentation in the chart. It's available both in person and virtually. And you can use this if you're in distress, but you'll note that it's also available in a proactive way. If you just want to establish a relationship to help you navigate the challenges of the professional career in a rigorous academic setting, you can use this for coaching. We also have the Coaching for Clinicians program. This is certified professional coaches. If you're a CE, you can use STAP funds for this. If you don't have STAP funds, WellMD subsidizes most of this. These are, in the community, coaching costs $300 to $400 per session. Even if you only have the subsidy, we subsidize all but $25 per session. And so again, this is a proven approach from multiple randomized trials for individuals, and I hope you'll use these resources. We have our peer support program, legally protected, can't be discovered in a malpractice suit, to discuss personal challenges with a trained colleague or a professional challenge that's come up. Dr. Alvarez leads this for our WellMD Center. We have a concierge offering that we have very high uptake by our Stanford faculty, but still less than half, I think. So we hope you'll use this resource. And then an initiative that originated with the Faculty Senate and in partnership with the hospital and the WellMD Center, we've been able to stand this up such that if you're having difficulty identifying your own physician at Stanford or coordinating your care, your imaging, your testing in a way that's disruptive to your own work, please try initially using the standard schedule. But if you are stuck or struggling, reach out to us and we can help you here navigate this and grease the gears in WellMD. So finally, let's conclude in thinking about the department. Each department also has to address those department-specific needs, and this involves assessment, and we need initiatives to address each of these components, including keeping members of the department up to date on what the department is doing. Leader behavior is a critical element. This is data looking at 2,400 physicians evaluating 129 division chiefs. Leader behavior scale, it's the scale we now use at Stanford. How often does your leader demonstrate this behavior? Every 1 point more favorable on this 60-point scale, lower burnout, higher satisfaction. But what's most striking in this study is that aggregate behavior score of each chief explained 50%, this is the R-square, of the variability and satisfaction with the organization across the 129 units. So this is a huge driver. Lottie did a follow-up study. Healthcare workers of all types, 40,000, found the same effect, and also longitudinal data that chief behavior score today predicts physician burnout in the unit 2 years from now. So we need to help our leaders build skill in the specific dimensions of leadership most relevant to the well-being and professional fulfillment of the members of their team, their division, which isn't always the skill building we provide them. And so I'll mention here that we now assess this in every one of our chief. It's one of the things you complete on the survey. That data is used for feedback to chiefs in a confidential way. And then we have a number of skill building opportunities, professional development opportunities to help our chiefs become effective in this dimension that they often haven't received training in. The last thing is, how do we get at some of that variability in the departments? Of course, leader behavior matters to all, but the other pain points for departments differs. These are our Stanford departments in rows. You see the column headers are different driver dimensions that we assess on the survey: efficiency of practice, teamwork, values alignment. The numbers are the effect size difference from average in the department relative to the Stanford medicine average overall. More than 0.2 to the negative or positive is of meaning. And what you note is that sometimes all dimensions are favorable or unfavorable. We often see this, where what's working in Department L and what's not working is a mirror image of what's working and not working in Department A. We now have each department is required to create a department-specific annual plan that assesses current state, gaps and opportunities, and which will be prioritized to close this year. Creation of input channels. Departments all have to submit a plan to us on how they're going to mitigate the adverse impact of work on personal relationships, optimize efficiency, and eliminate a burden in the practice environment, and then foster community and connection. They also have to submit a formal A3 improvement project in one of these 4 domains, and then a communication plan. I have to give credit to the Department of Medicine, the efforts by Bob and Kathy in years past to routinely evaluate equity in pay by gender and rank. They found a gap. They've spent years closing that gap, and we now are incentivizing other departments to follow that lead of the Department of Medicine to create inbox coverage, mitigate impact of work on personal relationships, and address inefficiency. These are the departments, which one of those rows are departments at Stanford are working on this year. You note the Department of Medicine is working on inbox coverage for faculty while they're on vacation and trying to make that consistent across the whole enterprise. But every department is working on A3 improvement project in one of these domains. Every department now has a well-being director. These individuals have a 20% funded time to lead improvement work on behalf of the department. Dr. Weinlander is leading the Department of Medicine efforts. And as all of you know, that heat map I showed you for the departments doesn't really capture what's going on in the Department of Medicine. What I'm showing you here is the heat map of those different driver dimensions for the divisions of the Department of Medicine. And here again, you'll note that what should be the focus area in Division C is almost the opposite of what's working well and not working well in Division I. Ava has now helped build out a group of leaders within each division of the Department of Medicine. These are your division level well-being improvement leaders. And I think as a credit to the Department of Medicine, these are not volunteers. They all get funded time. It's not a lot, but they all get 5% funded time to advance the improvement work in the division, even as Ava and the department work on department level efforts. So please note who's the person in your division and be a partner to them so that they can have your support and be more effective in the work. Lastly, at the department level, we have each department sort of grade itself in 4 dimensions, which are the rows, by the criteria in the columns, level of maturity. And what we've seen is that there's been advancing maturity of how substantive the department efforts are in each of those 4 domains. We give each department an overall score. This was as of when we published it, looking at the lowest scoring domain. So to be advanced, they have to be fully advanced in all 4 domains. And in concert with that structure and process improvement, we have seen professional fulfillment advances across Stanford. What I'm showing you here is specialty-specific national comparison to Stanford. So if this was the Department of Emergency Medicine, this would be emergency medicine at Stanford relative to emergency medicine national at this point in time. And you see we were average, most within the expected variability of national average, a few better, a few worse. All have improved relative to their specialty-specific national averages, 16 of 18 now favorable relative to specialty-specific averages. The burnout data is in the publications in reverse, 12 of 18 favorable to their benchmark in this domain. And this is what happens as we work broadly as well as in the departments. We need your feedback. There's many input channels. You can always email our Chief Wellness Officer inbox with comments. please complete the survey. If you haven't yet, the Department of Medicine is doing really well, but there's a lot of variation by division, with the highest participation rate so far at about 70% and the lowest division at 20% in the department. And again, this data helps the department prioritize where attention will be focused and your chief understand what can be worked on in the division. But with my last 2 minutes, I'd like to come back to that other side of the coin of our professional culture. And when we've looked at physicians, why are we unfavorable relative to US workers in other fields? And what we see is that we have higher meaning in work. I already shared the data that we have higher personal resilience. Our fatigue scores are equal. But we now have 4 dimensions. 2 are published, 1 in press and 1 to be submitted, where we score unfavorable relative to workers in other fields. And that is low self-compassion. We're compassionate with others, but we're harsh, perfectionistic, and self-critical to ourselves. Despite our accomplishments, we always feel it's never good enough. We have higher isolation scores than workers in other fields. And we have a greater adverse impact of work on personal relationships, even after we adjust for work hours. And this speaks to our professional culture. As we've moved over time from maybe where we were 30 years ago in the profession, we've been in this sort of early phase of the well-being movement where we talk about wellness and work-life balance and other variables. But we have to move forward to this next phase of recognizing we are human. We can do incredible things, but we are not superhuman, and that we need to foster work-life integration and self-compassion and meaning and purpose. And it was to help advance that dialogue that this video was created and this initiative in the WellMD Center. I want to thank members of the Department of Medicine. Multiple of Department of Medicine members participated in the video, and also thank Dr. Shireen Hideri, whose 2022 New England Journal Perspective piece was one of several pieces that helped inspire this movement. And I think what's exciting to me is beyond our individual engagement and conversations around this as faculty, our leaders are engaging in this. Dr. Maldonado is having a session with all of the chiefs and leaders in the department to consider how they see this impacting members of the department and how the department should act. And the executive team and senior operational leaders of the adult hospital, those 40 leaders, will be doing a similar session next Monday, thinking about how this should affect hospital leadership. So we're on a journey. We've made some progress, but we have a lot more to do, and we need you to help accelerate these efforts. And I'll conclude there, Bonnie and Errol, and again, please send us your comments and invites either at the Chief Wellness Officer box or my personal email, and happy to take questions with whatever time we have.
Thank you so much, Dr. Shanafelt. That was excellent. I might just, we have a number of questions. Thanks for people who are voting. I'm going to try to get to as many as possible. I'm going to go with, well, Dr. Barman actually has a couple of questions here that have received a lot of upvotes. Her first question, I'll put them together in essence time. Have you looked at gender equity in admin support within our department? I appreciate you've looked at salary equity, but admin support is also important. She also asks, between 2021 and 2024, is the improvement of the most burnout because some people have left the profession?
Yeah. So it's a great question. The second one part is maybe a little bit easier. I don't think it's because people have left the profession, unless it's that they've left in unequal proportions, right? That we would have to have a much different attrition rate at Stanford than elsewhere, which would again be a marker that Stanford's doing some good things. We obviously have much more to do. So I think that that could be part of the story, but maybe not the whole story. What was interesting too, just if we take the national level only, what we find is that the number of people leaving the profession is actually very low. But what's high is the number of people staying in the profession, but reducing their professional work effort. So moving to less than full time. And that's where we're seeing the big shift. The question about differences in admin support is a fantastic one. And I am not aware, maybe Bonnie is, of a department that's specifically taken that question on. I think, again, it's one that's tricky because, what does that look like in CT surgery versus dermatology versus cardiology versus endocrine gets really nuanced. So it's probably best done by the departments and the divisions, but it's a worthy thing to do. And so it's a great thing. And Bonnie, I don't know if you have comments there.
Yeah, no, I'm not familiar with that. Sorry. That's a good question, though.
Absolutely.
There's a great question here by Dr. Anand. Is there a fundamental problem of expected supply of physician's time, i.e., the number of patients we are expected to see in a clinic day? Is the quality of our interactions and documentation driven by the number of these interactions we need to have? Would the sacrifice of quality for quantity lead to our sense of lack of meaning?
I think yes to all of those. And the qualifier, I would say, is it doesn't have to be that way. And so a simple example is, every minute we spend creating a note, well, some of that is value added time, but much of it is not. And so we could see the same number of patients in a much more efficient way if we relieve some of the burdens associated with patient care. I think one of the things I am really excited about, I've been very much a skeptic on how much AI is going to help us. It's been promised for over a decade, but I think we're really on the cusp of something incredible. And having seen, what the ambient generative AI documentation of notes, where you just put down your iPhone in the room and you walk out and the note is fully written, and having seen the quality of that note, it is unbelievable. And Stanford is one of the first centers in the world that decided to write the big check of not piloting that in a small way. But as you probably saw a month ago, Stanford has signed a contract with Microsoft to make that available to all of our physicians. The Division of Primary Care and Internal Medicine will be sort of ground zero where it's first launched over the next few months. And I think, Errol, to this question, that will probably substantively reduce documentation time for many people. And so they're seeing the same volume of patients with much less of their own time allocated. And I think those are the type of interventions we need because they preserve access, but in a way that's sustainable and not just taking it out of physicians' personal time.
You read the minds of our next question, essentially answered it. Dr. Golden, Dr. Georgie had asked about the AI in medicine. What's the impact going to be? It sounds like it's going to be impactful. Dr. Gold, I'm not aware of that. You mentioned Kaiser recently bought Nambla. I guess it's an AI to integrate in Epic. So it sounds like what you're already talking about is we're going to see a lot more AI, and hopefully it will have a huge impact on.
Yes, and Stanford has as well. We're using the Microsoft product. But as you may have seen, a big announcement, and that is system-wide. That is the Children's Hospital, the Adult Hospital, all of our SMP physicians, the PCHA Children's Network, all of our physicians at all locations and sites will have access to that. There are very few. It's a multi-million-dollar investment annually, and to my knowledge, there are very few organizations that have made the whole system-level investment. Stanford is one of the first.
Dr. Shanafelt, as we end here, you mentioned some of the services, and if it's okay, when we send out the recording of this, we'll send a link to all those services. I'll personally say the concierge one, I remind our faculty all the time, I've used it. They're amazing. They help you, faculty, family, any faculty help get appointments for you personally and navigate the whole system. And they're available 24/7. You email them, and anytime they get back to you quickly. It's unbelievable.
Awesome.
And there's lots of amazing resources like that a lot of our faculty still aren't aware of. So we'll send that out. I did get a question asking about who qualifies for it. For example, affiliate faculty, VA, people in the VA, the affiliate Stanford appointments, the community folks. Can you clarify that? And we'll also send that out an email.
So because of some of the Stark laws and so forth, it's been a little bit complicated. The easiest answer is benefits eligible faculty, regardless of where they practice, are eligible. We've been able to also for the SMP physicians and the SMP UMP physicians in the affiliated network, come up with a way in which that group is providing the funds for it, so we don't get into Stark law, so they have access to it. But if a person have questions, they can reach out to us. We're trying to make it available as broadly as we can to everyone without getting ourselves in trouble with Stark law.
Well, thank you for that. There's a lot of comments saying thank you for all the amazing presentation and especially the amazing work you do to support us since you've come to Stanford years ago. Thank you, Dr. Shanafelt, for being here with us today. We hope to have you
Carol,
back.
can I make one comment on that too?
Yes, yes,
Thank
please.
you. Thank you for that comment. But I always want to just draw a notion that Stanford's efforts in this space are just so much bigger than the WellMD Center. And again, I say that because I think it really illustrates the institutional commitment. All of the work Bonnie's team does in OFDD, that is all wellness work. The work Linda Boxer and her team do is wellness work. There are many other things going on with some of our, hospital leaders, the med staff committee and so forth that, I think speaks the notion that we have many leaders who are trying to do the things to improve this environment. So please be encouraged by that broad effort as well.
When CME came out with a ability for us to deal with the new laws of getting trained for opioids, I was joking and saying that is one of the most important wellness things we've had. They made it so much easier for us. Right. It was amazing, and they've been amazing. And yeah, I see what you mean. There's wellness happening everywhere.
Yeah.
So thank you for your work, regardless, and for being our leader in the space. Thank you, Dr. Maldonado, and everybody for sticking with us. Hope you have a great rest of the day. It's a wonderful day today, so please get outside and see you next time.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.